Hello, my name's Tim Bertelsman, and like you, I spend my day caring for patients. But I'm also the co-founder of ChiroUp.com, so I spend my weekends educating evidence-based providers about best practices throughout the country. And today I'd like to tell you what I know about treating rotator cuff tendinopathy, which by the way is very different from rotator cuff tendinitis. My treatment of this problem changed dramatically 5 years ago, when Mary came in with a classic rotator cuff presentation. I applied all the tools in my toolbox, and on the fourth visit, Mary didn't show up. When I asked the staff, they said that Mary called in, she said she wasn't improving, she wasn't coming back, and she was going to see her doctor. That was a terrible feeling, and I didn't want that again. I knew I could do better, so I set out to create a better recipe. I ordered books, I went online, I talked to all the experts that I could find, and we developed a recipe that had 4 essential components. Number 1 is that we needed the most significant tests for diagnosing rotator cuff problems. This would include the empty can test, which is applying a downward pressure on the patient's outstretched arm. We also look for positive signs of impingement because that's present in 95% of patients who have rotator cuff tendinopathy. Impingement signs would include Neer's test, which is passively moving the patient's straightened arm into forward flexion, and Hawkins-Kennedy test, which is gently forcing the patient's elevated arm into internal rotation. No one test can give us a clear diagnostic picture. When we put them together in a cluster, we have much better predictability. Muriel and Walton taught us that by using the aforementioned tests, as well as looking at weakness and external rotation in the patient's age, we can have a 98% probability of a full thickness tear when 3 of 4 of those are present. One more really useful test is the external rotation lag sign. This is seeing if the patient can hold their slightly abducted arm in external rotation. 98% of those with a full thickness rotator cuff tear are unable to perform that test comfortably. The second point to managing this is to recognize that rotator cuff problems are generally tendinopathy, not tendinitis, and those are very different. The old thought process was that a tendon became irritated and inflamed and red and swollen. The new thought process is that it's not chronic inflammation. In fact, it's failed inflammation, which leads to failed healing. This tendon is not red and swollen, it's degenerated. It's turning to beef jerky. And that's a cycle, a self-perpetuating cycle, that if there's a single insult, yes, there is inflammation. The body heals it and it comes back to normal. But if that insult persists, it leads to failed healing with weakness, and that weakness unfortunately involves the supraspinatus tendon in this case, and the supraspinatus job is to depress and retract the humeral head during arm elevation. So when it's not performing its job due to damage and weakness, the humeral head rides up, creating greater insult and ongoing impingement. So our treatment of this problem is just the opposite of what I had done for Mary. Instead of being nice with things like anti-inflammatory modalities and ice and maybe recommending NSAIDs, we need to create a controlled inflammatory reaction. So now we do things like transverse friction massage or IASTM or factor technique. We incorporate exercises like eccentric exercises, which are more effective. And we also need to move to point number 3, identifying those functional deficits that caused and perpetuate this problem in the first place. This case, like nearly all impingement and rotator cuff cases, start with scapular dyskinesis, meaning that the shoulder blade's not moving the way that it should. This leads to impingement because when the humeral head and arm are elevated, the humeral head comes up toward the hard bony acromion, and that pinches the soft subacromial bursa and supraspinatus tendon. In order for this not to occur, the scapula has to rock out of the way at a 2-to-1 rhythm. And so we can observe that through the scapulohumeral rhythm test. When the patient elevates their arm, for every 2 degrees of arm elevation, there should be 1 degree of scapular rocking. And when that's present, we can confirm that scapular dyskinesis is contributing to the patient's pain with the scapular assistance test. This is where we have the patient move their arm naturally into impingement, and then we artificially rock their scapula and see if the pain goes away. When that happens, we've confirmed that scapular dyskinesis is contributing to their pain, but we've also educated the patient that if they rehab that mechanics, they can get that pain to go away, which leads us into the final point number 4. We need to prescribe the most appropriate exercises. Almost all cases of rotator cuff problem need to have the pec stretched, and we also need to stretch the short head of the biceps. Then we need to strengthen the serratus anterior and the lower trapezius, and we can do that through exercises like the YTWL, which is a gentle way to encourage scapular movement. We'll incorporate a low row, which keeps the patient's shoulder out of an impingement but strengthens those stabilizers. And we're going to incorporate eccentric strengthening exercises for the supraspinatus when that's present. Once I started identifying scapular dyskinesis and treating it with the appropriate exercises, not only did I get those patients to improve, but their improvement lasted. I learned that there's a big difference between treating someone and applying best practices. My uncertainty in these cases changed to confidence. Now I enjoy seeing them. And I know that I have the best recipe. This recipe is used by hundreds of other providers throughout the world to achieve greater than 70% improvement within the first 6 visits. And I'd like to share this recipe with you. You can visit chiroup.com today to see every treatment that we've talked about, every assessment, and every exercise in great detail for rotator cuff tendinopathy, shoulder impingement, and 90 other conditions. But more importantly, you're joining a fellowship of like-minded providers who envision a different world where chiropractic is the undeniable best choice for patients and payers alike. By working together and sharing our recipes, employing best practices, we can make a difference. We hope you'll join our team today. Visit chiroup.com to get started. Thanks for watching.